Good afternoon, everyone. My name is Stephanie Black. I'm the Director of Continuing Education for the Ontario Shelter Medicine Association. Thank you for joining us today for a Q&A with Dr. Scott Weese about COVID, which is paramount and very much on the forefront of all of our minds these days. First of all, I want to thank our sponsor, Boehringer Ingelheim, for making this possible. We have Dr. Walt Ingerson from BI that's going to speak to us for a couple of minutes about a new product they are launching. So go ahead, Dr. Ingerson.
Oh, hey, everybody. And yes, thank you so much. It's a true pleasure not only to be a sponsor of today's event, but also to attend today's question and answer session on a topic that, Steph, as you've already alluded to, still dominates so much of our personal and professional lives. So thank you to the OSMA for organizing this, and kudos for being able to get Dr. Scott Weese, probably and arguably the most sought after authority on this topic, to join us for this question and answer period. As you mentioned, I appreciate also the opportunity as sponsor to give you and all of the attendees a very brief update on Boehringer Ingelheim's newest product release, a new member to the NexGard family, NexGard Combo, the first true all-in-one comprehensive ecto and endo parasiticide product for use in cats. So I am hoping to go to the next slide, but it seems to not want to let me to do that. Apologies. It was working when we did this not too long ago. So apologies, I don't seem to be able to move it to the next slide, but let me see if I can simply wing my way through the presentation without the benefit of the slides. The reason we're very, very excited about this product in cats is because cats are fairly unique. We know they're not small dogs. They're particularly unique when it comes to their parasitic risk, because they are innate hunters. Whether they're outdoors or indoors, they will hunt. And considering their favorite prey would be small rodents, which are often paratenic or intermediate hosts for a number of parasites, their risk for multi-parasitism is quite high. On top of that, they are also, when outdoors, not supervised. They're not on the end of a leash. And so it becomes difficult to easily acquire a stool sample for regular testing, but it also increases the risk from a zoonotic disease potential, as they do defecate outdoors in areas where it's common for people to be, gardens, children in sandboxes. So again, a multi-endo-ecto-parasiticide product would make very great relevance for the cat. What is NexGard Combo? It's a combination of 3 ingredients: Essa-foxolaner, part of the isoxazoline class of ectoparasiticides. It provides very, very broad coverage and per label for fleas, ticks, and ear mites. And then from an endoparasiticide perspective, there's 2 ingredients to NexGard Combo. The first is a aprinomectin, a macrocytic lactone for GI nematode and heartworm prevention, as well as praziquantel, which will provide broad tapeworm treatment. It is all put together in a topical, once a month product for administration. There's no minimum weight. There is a 0.3 ml applicator for cats up to 2.5 kilograms, and then between there and 7.5 kilograms, another 0.9 ml applicator. And we're really quite excited that all of these 3 ingredients are put together with excipients, or the stabilizer carrying agents, that are really designed to be quite, to provide a quite comfortable administration. Dimethyl isorbide is the emulsifier that keeps the product in stable solution, as well as allowing it to be cross the skin from a transdermal delivery point of view. It is found in a lot of human topical products, acne medications, tanning products. Glycerol formol is similar from a product homogeneity, keeping it in solution point of view. And what makes this unique is that most other topical products are either based on alcohol petroleum byproducts and or have DEET in them, which for a cat very sensitive to the skin and a groomer can at times pose some concerns. And so when it comes to safety, a very brief overview, we have a host of clinical trials, principally therapeutic or toxic therapeutic toxicity trials that looked at 1, 3, and 5 times the labeled dose in kittens as young as 8 weeks of age. And other than some mild salivation, the occasional vomiting that we assumed were based on cats grooming the site of administration, there were really no real issues or concerns. One cat in the 5 times treatment group did have a very transient period of ataxia. That lasted only for about 9 hours. It was at the 3rd dose at the 5 times treatment level, but then did not occur when that was administered for the 4th and the 5th time. Similarly, over 11 field trials with representing over 1,000 or 1,100 cats and over 2,000 doses demonstrated that what we saw in the therapeutic toxicity trials found its way or was also similarly reflected in the field trials. So again, very safe product. From an efficacy point of view, I mentioned, again, very broad flea, tick, ear mite, GI nematodes, principally roundworms, and tapeworms control, as well as heartworm prevention. We also have it all backed up by an assurance program that supports its very broad and comprehensive efficacy as a true, again, all-in-one ecto-endoparasiticide product. This is the newest addition to the NexGard family. It joins NexGard and NexGard Spectra. I think products that have been on the market for a while and that individuals are probably fairly comfortable using. And for those that are not familiar, we're also quite proud of the NexGard Spectra having a label claim extension for the reduction of Borrelia transmission, being very effective at preventing Borrelia transmission from Ixodes ticks. And it's on both labels for NexGard and NexGard Spectra because the dose of afoxolaner is the same. And then we also have a Demodex treatment label claim extension for NexGard Spectra. So again, that was a brief overview. I hope that's given you some food for thought. For those interested in learning more about any of the NexGard family products, please don't hesitate to contact me, walt.ingwerson@boehringer-ingelheim.com, or probably more relevant, if you wanted to contact your territory manager from Boehringer Ingelheim, they'd be more than happy to fill you in on some additional details. Apologies for the technical errors. Hopefully watching me walk my way through it without slide accompaniment wasn't too boring. I appreciate the time.
Thank you so much, Dr. Ingerson. That's a very exciting product. So that's excellent. Thank you so much for sharing. So now before I introduce our speaker, a couple of housekeeping items. I have a number of questions that were submitted ahead of time, and I will start through those. If you have a question that is relevant to what Dr. Weese is talking about at the time, please feel free to put it in the chat window, and we will try to add that before we move on to the next question. Once we've worked through all our pre-submitted questions, we can, if people want to raise their hands, I'll unmute you and you can have a conversation with Dr. Weese. Thank you so much for joining us today, Dr. Weese. Dr. Weese is a veterinary internist, a diplomat of the American College of Veterinary Internal Medicine, and a fellow of the Canadian Academy of Health Sciences. He is a professor at the Ontario Veterinary College, University of Guelph, director of the University of Guelph Centre for Public Health and Zoonosis, chief of infection control at the Ontario Veterinary College's Health Sciences Centre, and is a member of the tripartite Global Leaders Group on AMR. So welcome, Dr. Weese. Thank you so much for joining us today.
Great, thanks, Steph, no problem.
So I think the first question was, should shelters continue a 2-vaccine mandate? And if so, for staff only or for the public also?
Yeah, I think that there aren't a lot of straight answers. I guess there's maybe the science and then there's the logistics side. So if we're thinking full vaccination, it's 3 doses. It's pretty clear. And we need to get around some of the terminology. It's not 2 doses and a booster. It's a 3-dose initial series. And certainly we have lots of precedent for that in other human vaccines and in some animal vaccines. So if you want to say we want people to be fully vaccinated, that means 3 doses. Whether there'll be more boosters down the road, we don't really know. And whether there'll be variant specific boosters, we don't really know at this point. But I think if we're going to have a requirement for vaccination, we might as well have a very functional one, which would be 3 doses. Now, the question is, should that be done? And that becomes more of a challenge. And really, when it comes down to, should we require vaccination in the shelter? Well, it's going to lower the risk. Vaccination is not perfect. It's going to bring in some logistical challenges. And part of it comes down to assessing the risk. And, it's what hill are you going to die on, realistically. Vaccination isn't going to be the solution to all our problems. Like vaccination is a huge thing. Vaccination has saved, millions upon millions of lives, but it's not the sole thing that we need to do. And what we don't want to do is have people say, okay, well, we've got a vaccination requirement, so we don't need to do anything else. We want to find that sweet spot where we're using all our tools really well, and vaccination is one of them. And when it comes to who can be vaccinated, well, it's basically everyone. There's a small percentage of the population that can't be vaccinated, but it's a really small percentage. And if someone's been told they shouldn't be vaccinated, they really should be going to a specialist on that, because there are only a couple really, really narrow groups of people that can't be vaccinated. And it mainly comes down to really rare allergies to components of the vaccine. So there are a lot of people that, have been told maybe you shouldn't get vaccinated. But when they go to a specialist, it's, yeah, you can be vaccinated, or often it's, yeah, you really should get vaccinated because you're at higher risk. So when it comes down to, it's getting a rambling answer, but thinking about your own facility, what's the vaccine coverage right now? What's the disease prevalence in the area? What's the vaccine hesitancy in the population? What's the risk to the population? Because really we need to think about what vaccination is there to do, is to prevent severe disease. That's what it does a really good job at, preventing death and severe disease. So the impact of that is going to be higher when you've got a higher risk population. So if we have people that can't be vaccinated, which is uncommon, like I said, if we have people that are older, have other health problems, who are the more likely to get really sick, you get more of a protective effect by vaccination and by everything else that comes into play. But we need to think about all the other stuff. You can't say, okay, we're going to vaccinate, so we're not going to worry about ventilation. We're not going to worry about mixing, and I can cough in your face all I want because we're all vaccinated. Well, that's not going to help us as much as it could if we had that as part of an overall program.
Well, the second part of this question, you actually kind of already answered, and it was about whether we should be putting 3 vaccine mandates in place. So if facilities are keeping the vaccine mandate, should they be upgrading them to a 3 vaccine mandate?
Yeah, if you're going to have a vaccine requirement, you might as well have one that works, right? If you're going to go through the hassle and some of the problems that are come with requiring vaccination, you should require it fully. 2 doses are good. 3 doses are clearly what we need to have that high level of protection.
Okay, perfect. Now you spoke about specialists and referring people to a specialist for vaccine exemptions. Is what specific type of specialist? Because we've had people with doctor's notes, but that would be from their regular doctor. So where would you recommend we send people? And are we allowed to send people?
Yeah, that's what they talk to their doctor. It's an allergist. So the 2 main groups of people that can't be vaccinated, if you've had a problem before with the first dose of the mRNA vaccine, so you've had vaccine-associated myocarditis, which is really rare and a lot less common than COVID-associated myocarditis, but it's real. So if someone's had that before, then they need a risk assessment to whether it's worth getting a second dose of the vaccine. That's a very valid one. And the other is if they're allergic to a component of the vaccine, and that's really, really rare. It's not like egg allergies and older vaccines that were produced in eggs, which is fairly common. The allergy side is really rare. And you're looking at a couple people per 100,000, really, in terms of the population who can't be vaccinated. So someone's been, and sometimes we hear people that, they've had a reaction to another vaccine in the past, or they've had an immune system disorder or other things. And sometimes their physicians just say, okay, well, maybe you should hold off. And maybe that was said, a year ago when these vaccines were really new. So I think anyone that's been told and they don't have those clear 2 groups, the previous problem with the vaccine or a known allergy, they should be going to a specialist that can, do a proper risk assessment to see whether they should be vaccinated or not.
Okay, perfect. Now, Linda has just asked, do you think it is politically even possible for organizations like shelters to have a 3-dose vaccine mandate, given the removal of provincial mandates and increasingly federal?
Yeah, and that's the logistical challenge I was talking to before. It's what hill are you willing to die on? I think we can do it, absolutely. It's your facility. There have been various challenges to vaccination requirements, and they've basically all lost, including a lot in the US, which is a lot more litigation prone and probably a lot more, civil libertarian approach. So I don't think it'd be a problem with a facility doing it. It's a matter of, realistically, it's the hassle and disruption and all the other things that come along with it. So I think it's certainly possible to do it. But yeah, and I'm not saying don't do it. I'm being a bit waffly here because I think I have to be realistic and that most places aren't going to go there. Just because, right, we're withdrawing vaccination requirements in some areas. The next few weeks, we may see that being revisited a bit as we start to ramp up again, which is what we expect. Well, you have to come back to what's the cost benefit, right? So what's the cost benefit for the facility? What's the cost benefit for the animals? So on the cost benefit for the animal side, there's not much of a story right now because vaccination, is prevention of severe disease. It's not for prevention of transmission as much. It still does do that, but not as much as the severe disease side. And given at this point that the species that we see are low risk for severe disease, we don't have as much of that beneficial effect. If we were looking at mandating it, and if you're allowed to say, give me the few facilities you want to mandate vaccination, it's going to be wildlife rehab facilities that are dealing with deer or dealing with mustelids. So species that we know can be infected and can transmit it, and maybe we can develop a wildlife variant if we release it. So the wildlife rehab side is a completely separate issue. And if you're dealing with rehab and high risk rehab species, then you might need to think about that or have specific staff that can handle it. Maybe we only have the vaccinated staff handle deer that are admitted if you do that, which isn't very common, but mustelids. So I think you have to think about the overall picture, right? If you've got high risk people there, the value of it goes up. If you've got a compliant population, people that buy into it, the value goes up. If you've got a community where there's still a lot of disease going on, the value goes up. And we don't know what's going to happen with disease in the next few months. So, being proactive is always good. It's just, I realize logistically, most places aren't probably going to do it.
Now, there's a number of people had very similar questions. So hopefully if I ask it in a certain way, I'll cover a lot of people's questions. So what are the recommendations going forward to keep everyone safe in our different environments? So I guess the first thing is, should we be considering capacity limits still?
It's less capacity limits than what we do with them. So when we talk about control, we really talk about the 3 C's. And I've talked about that before. Maybe we're looking at crowded places with poor ventilation, or closed spaces with poor ventilation, crowded places, and close contact. So, if you bring 100 different people into a facility over the course of a day, that could be low risk or high risk. If they distributed in a big facility with good ventilation, multiple rooms over 10 hours, then there's not a lot of contact there. If they're all coming in at lunch and they're hanging around in one room where there's no ventilation and all your staff are interacting with them, there's quite substantial risk. So capacity limits kind of oversimplify things. We want to limit the number of people that are in as much as we can within reason. It's just more fuel to the fire, but we all want to limit, the number there any one point of time in any one place. So again, I could have 10 people in the shelter right now, and if they're well distributed, the risk is going to be really, really low. If they're all in one area, the risk is high. And then we bring in the ventilation aspect, which kind of mitigates that too. So it's not unreasonable to thinking about it, but capacity limits by themselves are kind of an easy thing to do, but they're not necessarily all that valuable because you have to look at it. And if it's a capacity limit that just says, okay, your facility is 10,000 square feet, so you divide that by whatever your jurisdiction says, and that's your limit. Doesn't make a lot of sense for most of our facilities because it's not like a mall where everyone can go 90% of the facility, right? So you do get distributed like that. You got, 10,000 square foot footprint, but you might only have 1,000 square feet where people are mixing, really. You got your staff that are distributed, but the other people that are coming in don't get the room at the place. So I think thinking about limiting the numbers is good, right? But that's limiting total numbers, that's limiting people there at any one time, and limiting people in any one place. And I think we can have more of an impact with that. So it's if we have people that are coming in for an interview, so instead of them, or meet an animal, or instead of them hanging around the waiting room with 10 other people, we try to figure out where they can go. And if we've got rooms where the animals are, where they're going to go, okay, the waiting room is that check-in room, and then they go somewhere else. So they get into reception, they get taken to this area and that area. So you don't have them congregating. And then we don't spend a lot of time with them. And if we do have spend time with them, we've got better ventilated areas, more stuff we can do outside. We're starting to get, well, not today, if you're around here where it's -20 wind chill, but we're getting to the time where we can do more outside things. So it's a lot of stuff we talked about, last year, maybe not quite as strict because we're getting to the point where there's a lot of reopening elsewhere. And it's hard to say, okay, you can do everything everywhere else, but in our shelter, you're not. But there are valid arguments to say why we should be a little stricter in shelter. And one is just that essential service component, right? That's why we keep shelters running, but it's also why we want to be careful. Because if 90% of your staff go down with COVID, what does that mean for shelter operations? And what does that mean for any animals need to come in? And we certainly know you can get really high attack rates. Universities right now, we're seeing really high attack rates in some classes. 20, 30, 40% of the students can go down at once. So if you get a good super shedder in your shelter and you've got a lot of people that they hang out and they've got, lunchroom time that are together and they're not masking and they create, a transmission environment, you may have a day next week where all of a sudden, 90% of your staff call in sick. And then what do you do, right? How do you do? So essentially you're running an outbreak type operations because you can't do anything else because you don't have the staff to do it. And that compromises care of the animals that are there, and that compromises care of the animals that come in. And I think that I bring this up because it's straightforward, but this is a selling point when you're talking to staff and when you're talking to people. Why do I have to wear a mask when I come in to see your dog and to see this dog? I'm just going to take it off when I get home. Well, if you infect us, this could impact a lot of animals. And euthanasia level impact, we can't bring in animals, we can't care for them. So I think we have to think about the unique aspects of shelters.
Okay, so based around that, then you would recommend that we maintain masking within our sheltering environment?
Yeah, masking is easy, right? It's easy and it's free, it's cheap. And it's another reminder that you're in a higher risk environment. You're not just walking down the street, where don't wear a mask when you're walking down the street right by yourself, but you're in an area and it comes down to your operations again. It's the package. So if you're in a room by yourself, yeah, you take the mask off. There is some risk because you're creating this cloud, the next person that comes in the room, but we kind of have to balance where we are in the pandemic and the measures that we can practically do. So when I go into my office, so I wear a mask on the way in. And when I'm in there, when I'm in a room doing stuff by myself, I take my mask off. I go out, check in the clinic, my mask's back on. It's not hard. We're pretty tuned into doing it. So I think it's an easy thing that we can do that we know drops the risk. Doesn't eliminate it by any means, but the more of these little things that you can do, the more you can get away with other things. So the better masking means you can let more people in, and we can get by with the inherently poor ventilation that a lot of our places have. So I think understanding all that, but masking is one of the last things I would drop just because, it's not that disruptive. It's annoying. We'd like to get rid of it.
Right.
And it also maybe helps dry, it's a reminder that we're still doing things. And it's also a reminder that while we can go outside and maybe drop the masks and do things safely outside that way. So it's maybe a bit of a carrot to get people spreading out a little bit more.
True. Okay. Now, once we're looking a couple months down the road, one of the questions that came forward, so not right now, because you said to keep the masks, but let's say 2-3 months from now, when the numbers are even lower, they said, we have one staff member in our animal hospital that cannot receive a vaccine due to health reasons as recommended by her doctor. The rest of us are fully vaccinated, and many of us have also had COVID. I was going to recommend that we continue to wear masks when we cannot be socially distanced. Is this a reasonable approach as they move towards removing masks?
Yeah, I think masks are easy and cheap. There's no reason not to do it. If you've got an unvaccinated person in the clinic, then how much does that increase the risk to the clinic? It's hard to say. Your unvaccinated staff person is going to get COVID, and they're going to get it multiple times, probably, because we know that immunity from natural infection is not great. So they're going to be a higher risk. If someone's had 3 doses and they get infected from a breakthrough Omicron infection, they're going to be pretty well protected for a while, a lot better protected than your unvaccinated person. So the unvaccinated person, if this was a vaccine that really stopped transmission completely, your unvaccinated person would pose a substantial relative risk. Here they pose a greater risk, but not probably a massively greater risk where we are right now. If you only have 2 doses of vaccine, then that risk, the difference in the risk probably starts dropping even more because 2 doses aren't as good as 3 doses. So it's looking at that whole picture. But yeah, if you've got circumstances that increase your risk, and that's both increasing your risk for severe disease because you've got high risk people in there, or increase your risk for bringing things in, or you have staff members that have young kids that are caretakers of high-risk population. So, it's not necessarily all the personnel, just their risk, but if you've got someone that's got a baby, that's a concern. Someone that's pregnant, that's a concern. Or, it might be someone taking care of their elderly parent, grandparent. Like those are all situations where, again, we want to drop that risk of severe outcome, and dropping exposure is a big part of that. So the short answer is, yeah, I would just keep masking until, for now. I think masking might be the type of thing where we end up going in waves with it too. I think we still need to do it now, because if you look at where we are with cases, like we're higher than we've been most of this pandemic, apart from our kind of January Omicron wave. Like our case numbers now are pretty substantial still, and we've just stopped reporting them or testing, so we don't know the whole extent of it, and we've grown somewhat immune to it, behaviorally. So this still is a pretty big time, and we're probably going to see our ICU numbers start to come back up. So it's not like we're at the end of this, and people say we're into the endemic phase, and really the modeling shows that endemicity isn't something we're going to see this summer. Endemicity is something we're going to see over 5 to 10 years, because we're going to see this go up and down. Winters are going to be bad. Next winter is going to have some problems. January is going to be a bad time because it's flu season, right? It's indoor respiratory virus season. And depending what the dynamics of vaccine and vaccine protection are and boosters are, we can easily get big waves of disease. So not to be overly pessimistic, it's just meant to remind us that, just because the government said you can stop wearing masks now, doesn't mean we're done. It means they decided to say you can stop wearing masks now, and we're going to have issues. So where it comes back to what Sam starting with this rambling statement was, we're probably going to be in a situation, in an era, maybe for years, where you have to have masks as a pull it out as needed thing. So we need to work on education to stay home when you're sick, that culture of attendance that we're still trying to work on correcting. But it might just be, okay, we've got this number of cases in the facility or in the community, so we're wearing masks for the next week. We'll revisit it again. And, it's probably not going to be that big a deal for most people. Like we're so used to it being, oh crap, I have to wear a mask again. But no, let's wear a mask so that we can get rid of them sooner, might be the approach. So I think I don't think we've seen the end of masks completely.
Okay. Now this kind of leads into, and you've answered some of this question. So the question was, can you talk about a strategy that's not the all or none as cases rise and fall and hospital capacity changes?
Well, I think it's probably what we've been talking about here, right? It's thinking about all the different things we can do. We can optimize vaccination, and it doesn't, it's not all or nothing on vaccination. It doesn't mean you say we're going 3 doses or nothing. It means we can encourage it, right? You just get education out there, you support, okay. Part of this is just, we strongly recommend getting a 3rd dose. And if you're going to get your 3rd dose, we know you might be off work for a couple of days. If you feel bad after it, fine, like free sick days for a couple of days after your 3rd dose, or you can take the day off. It's like something like that. You get a little bit of a carrot, because it's good for the facility. I'd rather have them away for a couple of days for a vaccine, and it really probably is anything 1 day at most, than have them get COVID and then be out for a week or worse, or they spread it, right? So, it's a cost, but it's a cost benefit thing. So let's maximize vaccination. Let's still keep working on looking at our facility and how can we improve ventilation? How do we improve flow? And a lot of these things can actually help us over time. So how much can we schedule stuff as opposed to wide open? It's always gonna be walk-in traffic probably, right? But if we can have things more spread out during the day, and maybe if sometimes a day, maybe you don't take walk-ins over noon or something like that, because it's a busier time and you have fewer staff, whatever it is. But I think you look at your operations and how do we address those 3 C's? The crowded places, the close contact settings, the poorly ventilated closed spaces. And we want to do something to address all of those. We can think about scheduling, we can think about how we're designed, we can think about potentially down the road building more individual rooms in. So instead of having people hang around, you've got these small spaces where they can go and they can do the animal interaction, they can do interview, pre-interview stuff. How much we can do by telemedicine, telesheltering, where initial conversations can be done electronically, and then to get to the point where they need to see the animal, you do that. But you don't have to do it all. So if we can turn a 1 hour visit into a half-hour visit, we've dropped our capacity needs by half, right? So you do the discussion at the start, maybe you figure they're never going to come in, right? You filtered that out pretty quickly, some people. But if they're going to come in, then they come in for a more targeted thing where you're not even there with them much. So instead of having that discussion and then they're going to meet the animal, you've done the discussion, you have the time with the animal where they're supervised, but you're not having that long-term conversation, which drops the risk even more and makes it more efficient potentially too. Someone can bang off a lot of Zoom interviews maybe more efficiently than trying to schedule people that come in late and get delayed and everything else. And you have someone, then the next day they do the in-person things. Like a lot of efficiencies we can maybe bring in. So I think a lot of it's just thinking about the concepts. We've got the 3 C's, we have the vaccination. What do we do to maximize that? How do we make sure people aren't coming in sick, which is a big thing. And that's again, a cultural thing that's, don't suck it up and come to work. That's the opposite of what we want these days.
Right. Now, to kind of shift gears a little bit, one of the questions was, what is the most bang for our buck with rapid testing strategy?
That's a great question because I don't think we know. It's a bit of a moving target. So what we know about rapid tests are, they're pretty good if you're really infected and you're infectious. So rapid tests are less sensitive than PCR. You've got a very narrow window time when they're positive, but that largely corresponds to when you're infectious. With PCR, you can have really low levels. You're not able to infect anyone, but you're still positive. So the good things there. The bad thing about the rapid tests are a lot of them don't work very well for Omicron. So you're dropping your ability to detect it. If you are using rapid tests, we want to do throat and nose. Most of these just say nose in the instructions, but we know throat is a higher yield site. So usually do the stick in your mouth, swish it around and stick it up your nose. So the combined swab, which sounds gross, but it's not that bad. But we wanted to do that because you'll get higher yield there. So when it comes to strategies though, we've kind of, if you look at it, if you're just doing like once a week or once every other week testing, we know it's really low yield. Yeah, you'll pick up some, but for the hassle, the cost involved, it's not that useful. Maybe less disruptive now because we have more tests. Like a few months ago, it was absolutely don't do that because it's really low yield testing and tests are like gold. Now we've got a lot more tests. But if you want to have much confidence, you need to be testing multiple times per week. So really you'd want to be testing 2 days in a row or 3 days in a row to be able to pick up these silent carriers, these silent infectious people. And that becomes a logistical challenge. So really for me, where testing is good is for, if they're sick, and this depends on where we are in the pandemic too. So right now, if someone's got signs of COVID, they've got COVID, make the assumption they've got COVID, stay at home. The rapid test can help confirm that, but if you're feeling like crap and you got a negative rapid test, you still have COVID until you take another test. So if someone has 2 negative tests while they're in the throes of illness, they probably don't have COVID, but you don't want them there anyway, right? Because you don't want to get flu and you don't want other people to have the same discussion. I'm sick, should I be staying home? So rapid tests are useful to know if it's going on, right? So it's not, we don't really use rapid tests as much. So can you come to work or not? Except in some circumstances where and this will get more useful in the next few months, where they might have a better role for that is you've got someone that's got allergies and they've got classical allergy signs during their season, right? So they have spring allergies and they've got a runny nose and runny eyes and they feel fine otherwise. And they say, it's my allergies. We've been burned on that before, right? So they probably just have allergies, but they can take a rapid test and that gives you that extra layer. It's not a guarantee, but it helps with that. So if you got a situation where they've got signs, but they're probably not relevant, let's go ahead and test them anyway. You could say the same thing for flu or rhinovirus, but at the same time, again, we don't really want them coming in to the shelter anyway. So when people are sick, it's useful just to confirm what's going on so you know whether you have COVID. And that's maybe the biggest thing. So if I'm sick today and I'm positive today, I can tell people that I was exposed to the last couple of days, okay, maybe we got something going on. If we want to use it for the test to stay, which means you're using it to allow you to go to work or stay at work, that's more when I've got allergies or some other atypical signs where I don't think there's a problem and I just want to make sure. And it's not going to be something that's going to be transmitted, going to infect people with allergies. The other thing to consider is when people have had COVID, testing to return. And that one's probably the most valuable because we've got this day 5, you can go back, and that was really designed to get people back to work and hope they didn't cause too much damage. It certainly wasn't there to control the virus because we know a pretty substantial percentage of people are positive on day 5. I got COVID about a month or so ago. I had 3 doses of vaccine. I got it from either teaching or a girls hockey team. So probably from breaking my girls hockey team. Really short-term exposure. I think kind of knocked me on my butt for a while. But I was still positive on day 6 and day 7 after the onset. And I was testing before I went anywhere. So I stayed away from the hockey team until I had a negative test two negative tests post day 5. And we've done that. We did that with some of our players too. And we had more than one that were still positive after their day 5 release. And that's a higher risk environment because they're breathing on each other on the ice. So that's one thing to consider, is using rapid tests as a return to work thing. Doesn't mean they're guaranteed not to be infectious, but if you're day 6 and you're still positive on your rapid test, stay home, because we know you're still likely infectious.
Makes sense. Now, there's been some people that say, I had these symptoms and I tested myself and I was negative, and then I tested myself and I was negative, and then I tested and I was positive. So all these people that are testing and testing and testing every day, and then finally, day 3, 4, 5, they're ending up positive. Is there an ideal testing window from the onset of clinical signs?
PCR anytime.
Right.
Rapid tests, you might need a day or so. Now, you often have pretty peak viral shedding around the time you get sick, but not always. And I'll give you my scenario. So I started to feel a little bit rough in the morning, and then the evening I did a rapid test, and I saw a line there, but it was, I was using my imaginoscope, and it's because I was really, really looking. I showed my wife. She said no, and I said, look at it this way. He said no. Like, look at it here. Whatever. I don't think so. And I said, that's a line. And then the next morning it was like fluorescent bright red. So part of it's, if you get it too early, is it's just ramping up. And if you're not really looking for it, a lot of people do miss positives, because you have to think any of that faint line is really a positive. You will get some just because that are negative, just because the tests aren't as good for Omicron, especially if you're just using a nasal swab. And you get some people that just aren't very good at nasal swab. It's like, I'm done, right? As opposed to, like, you're not trying to pith yourself, but you need to get it in there and twirl around, do both sides, and like ideally doing the mouth first. So part of that is sampling, part of it's a test, part of it's just the disease. If you've got someone that's done a good sample and they've had 2 tests when they've been symptomatic over 24 hours or more apart, it's pretty solid. Nothing's 100% with this virus, but a lot of it comes down to how good was the sample. So, if you got a really good sample, and you were sick for 12 or 24 hours for your first one, you've got a negative one 24 hours later, I'd be pretty confident you have flu or something else. Still say stay the hell away from me, but I'd be relatively confident you don't have it. But there are exceptions to all the rules.
Okay. Perfect. So that's the end of the questions that were pre-submitted. So I'm going to open it up to the group. And if you want to raise your hand, feel free to raise your hand and I'll unmute you. Or if you're more comfortable typing it into the chat window, please feel free to do so, and we'll get Dr. Weese to answer our questions as they come up. Does anyone have any questions?
That's why we had the pre-prepared ones in case everyone's silent.
Exactly. Linda's always good for a question or two. Linda, can you think of any questions? So she said that. Okay, so there's a couple people that are asking.
Yeah.
You can see them there. All right.
Yeah, that's a common question. And the animal side, I guess it's a multifaceted thing. So we just look at the animal side. So we know that infection of dogs and cats from COVID positive households is pretty high. Cats are over 50% are going to be infected. And cats do pose a risk of transmission. We're fairly confident, and there is some evidence they can infect people. So I mean, cats coming from a COVID positive household or a high risk COVID household are something we need to pay attention to. Dogs are pretty low risk. The infection rates are pretty high. Like, we're seeing 30 to 40% in our surveillance. They probably don't transmit it much, or if they do, it's a really narrow window. So we can start thinking about separating dogs and cats here, I think, realistically. Ferrets, I would put with cats, just as a higher risk species. Now, what to do with them is a bit of a guess. So if we look at cats, we don't have great long-term data, and the stuff we have is PCR, which kind of diagnoses how long they're infectious. But if we look at the viral load, it goes down fairly quickly after they're positive. So my guess is their cats are probably fairly similar to people. I wouldn't think there's any reason cats are more susceptible to this virus or shed it longer than we do. And we do see that fairly rapid decline. So I think cats, the risk is going to drop a lot by day 5. It's probably getting close to 0 by day 10. And I think it would be 0 by day 14. So I've kind of said that 10-day. Part of it comes down to logistics and how long and how much you know about the animal. If you can isolate them for 10 days, I think that's good. If isolation for 10 days, disrupts your shelter operations and you risk a feline upper respiratory outbreak because of it, then you maybe back it off a little bit. I wouldn't want to send them to a home that quickly or into a foster that quickly, unless like foster, maybe if they really know the circumstance. I think if we had to, we had to compromise and say we can only do it for 5 days, it gets a little bit scarier, but the risk is probably low. And what we would probably try to do, instead of saying is it binary, isolate or not, we'd say, okay, well, isolate them for 5 days. And then for 5 days, they're going to be strict cage in a common area if we have to, but in the cage that's farthest away from everyone else, and do some things to reduce aerosol-based transmission, just because there's maybe some degree of risk there, but it's pretty low. Dogs, I think we got 5 to 7 days, we're golden. And dogs, realistically, if you had to decide whether you're going to isolate a dog versus a cat, you're going to isolate the cat every day of the week. The dogs just pose limited risk, but we can't say zero because their surveillance isn't good enough. So I'm much more happy to push shorter term limits for dogs because I just don't think there's much of a risk. And I would think that by day 5 to 7, for sure, there's going to be essentially zero risk. So I would still isolate the high risk ones if you can. Doesn't really matter if they have respiratory disease or not. If they have respiratory disease, I'd be more concerned, A, that they're infected, but B, be more concerned they're going to infect someone, because a sneezing cat is going to infect you a lot easier than a non-sneezing cat, just from that aerosol. And same thing with a dog. Now, a dog that's barking is going to be aerosolizing it anyway, so there's no risk there. But if they've got respiratory disease and if it's unknown respiratory disease, right? If it's a chronic upper respiratory disease cat and it's got upper respiratory disease, I'd be a little less concerned about it. But still, if there's a lot of sneezing, there's more exposure there. So I think we can back it. We were saying 14 days at the start because that's what they're saying in people, and it's 2 weeks and it's a round number, and that's all it really went on. So I think we can drop that down. Like I said, 7 to 10. 10 is probably ideal world for cats, 5 to 7, but I think we can push most of those shorter if we have to for logistical reasons.
Okay, I think someone with the screen name Animal Shelter has had their hand up for a little while. If you want to go ahead and unmute yourself.
Sure, I think that's me. Sorry, this is Lindsay from the city of Pickering. I'm on my phone, so I don't know if what you might say about this. So I work for a municipal shelter, and so as we know, the province has said we no longer need to wear masks, and we no longer and we can kind of go up to opening. I know we talked about that. And I know you've earlier said we should still be trying to be able to, we encourage people to wear masks and look at our capacity limits. Is there any opportunity, any way that you can, I don't know, I'm going to say assist us, provide something in, I don't know, writing from the animal side perspective? Because I'm finding it, and I know it's over the next couple of weeks, the next couple of months, it's going to be difficult to try to continue to justify it just by me saying this is what we're saying. So I'm putting you on the spot, but I'm not sure if you can help us be able to do the right thing.
Yeah, I'd basically spin it around and say, what do you need? And we can probably come up with something, whether it's a FAQ or it's a recommendation, or it depends whether it's directed to staff or whether it's directed to visitors. So, something directed to visitors, why are we still doing COVID protocols? And the emphasis there might be, if we get an outbreak on our staff, animals are going to die, right? It's very simple.
Yeah.
Put a little more context to it. But and the same thing really could be directed to staff, a little different messaging, right? But here are the things that we're doing. We have to do a bunch of little things to do it. And we're in a higher risk environment. We're different than a long-term care facility, but we have the same issues in that an outbreak can cause a lot of damage, more than in the general population. If you get outbreak at McDonald's, they can shut down and people aren't going to die, or they've got enough staff. We get an outbreak here, we've compromised an essential service that we may not be able to recover from in a week or two. So I think it's probably that similar messaging.
Right.
But I'm happy to put something together. Partly, I guess, would be if anyone here, the group comes back, what do you need and who's it targeting? It's probably something we could put together really quickly and put it out under whatever banner.
All righty. I'm also thinking about, I was actually more thinking of it for like our senior management, our CEO, because it's coming from like the politicians who have kind of make the decisions on the municipal side to say, oh, okay, we're just going to stop doing everything. It's that kind of a thing. But perfect. I will reach out. And I'm also on behalf of the Association for Animal Shelter Administrators of Ontario. So that'll be fabulous. Thank you.
Yeah, I think for administrators, it's largely the same message, but maybe the added message is that opening up was meant to facilitate business operations. And we can operate a shelter with minimal disruption by maintaining some of these activities. And I think the point is, like, a lot of the stuff we can do is not that cumbersome, and it's not going to cost money. And, you know, it's masking, and it's encouraging vaccination. It's thinking about how we flow people through. It's assessing ventilation. It's stuff that's really good for other stuff. Like, if we improve ventilation, we improve cat health in terms of respiratory disease, and dog health in terms of respiratory disease, and staff, right? And if your shelter smells, you're inhaling a lot of volatile things, and that's going to impact staff health over time. So I think there are a lot of reasons to sell that we're using this to protect our animals and our staff. And it's going to be better for you because we'll have fewer sick people.
Exactly.
They'll
Thank
adopt
you.
it. Yeah, that's kind of the tack I would take there. So I think if you had audiences to direct it at, we could probably come up with something. Yeah.
Okay, great. Thanks.
Is that Cinda there or their hand up?
Yeah, so I guess
It is me.
Okay, I wonder about
All
that.
right,
Hey,
hey, here we go. All right, hey there. As always, thank you so much for your time and expertise and insights. There's a group of us in the shelter medicine education programs here in the US that have been discussing new recommendations for shelters in the United States with regard to dogs and cats coming from COVID households. And we put together a draft a couple of weeks ago that actually may sound a little bit controversial, but based on studies such as yours in the field, other people's studies in the field, there seems to be a very low number of cats, much less dogs, that are actually PCR positive or shedding virus at the time you enter the household and collect the swabs. Of course, very large seroconversion. But at least at the time that the investigators collect samples, the majority of the animals, vast majority of the animals are already having undetectable shedding, if any. We have a big premium on length of stay at an animal shelter, particularly if it's municipal shelter. And so it's very challenging for many, many shelters to quarantine asymptomatic dogs or cats that came from a COVID household. Of course, we early on did recommend the 14 days. But I think based on the field studies as well as the experimental studies, it seems the odds of a cat coming from a COVID household shedding virus are going to be extremely low.
Yeah, I guess the problem is, and there is some evidence of zoonotic transmission to vets, which will be coming out at some point. I think it's not mine to talk about, but so that raises some of the issue there. I think the problem with the studies is, and ours is, it's a timing issue, like you alluded to there, right? So someone's got to get COVID, and then they have to get diagnosed. They have to get the result back. They have to track us down. We have to get in the households. We were getting in late. But it depends on the scenario. And I think this is where you can build in the risk-based stuff. And this is where I'll do case by case thing. So the person so you got the senior citizen live by themselves, and they have a cat, and they have COVID, and they were sick for 5 or 6 days. And then they went to the doctor, and then they got admitted to hospital on day 7 or 8. I'm going to be much happier to narrow that window down based on the cat probably got exposed when that person was infected. And if the cat was infected, they're probably only got a couple of days left in the risk period or at all, versus someone, they're positive today and we have to get rid of the cat for some reason. So we have seen some situations. We had a large group, and a person went into hospital and died, and it was a hoarder with a large number of cats and a couple of dogs, and I can't remember how many positives we had, but we had multiple PCR positives from that population that went into the shelter. So I think we have to be a little bit careful on what percentage are infectious. I think overall it's going to be low. Like I agree with that, and that's where I think, that's what I said. Like it's the pragmatic side. How does it impact your shelter operations? And I would rather have you use your isolation for the hoarder that came, the animals that came in and they're really sick from the hoarder, than it would, the precautionary stuff for COVID ones. And this, this is where it's case by case. So you might divert some of these to a foster really quickly if you've got a triple vaccinated, otherwise healthy, well-informed foster, and that cat's probably been exposed to COVID for the last week or so. So it's lower risk. And then you talk about, mitigation practices in the households. Maybe it stays in a cage in the household for the first couple of days. Like I think we have to be flexible, absolutely. But I think we just have to be a little bit careful interpreting some of the studies, because I'm pretty sure we underdiagnosed. If we look at our serology is over 50% exposure. So they were infected at some point. What does that mean for their risk for transmission? Don't know. And I think the other thing we have to build in, and I was going to mention it before, and I didn't get around to it, it's community context too. We need to think about. So if you've got an area where it's rampant transmission in the community and no one is doing a thing to control it, the relative added risk from your animal is really, really low. And this is where we would wait more on, do as much as we can, because we don't want to add any more burden. But this is where the informed consent side would come in a little bit more, right? You're more likely, you got COVID ripping through your community in the southern US and no one's wearing a mask. 40% vaccination rate. You're more likely to get COVID talking to someone in the parking lot than you are adopting a cat. And that's probably true, right? So, and I think as long as we say, there's potential, this cat's only been here for 2 days, 3 days, whatever, but we recommend this, that, and the other thing, and we think the risk overall is really low. I think there's value in that. So that's why I'm kind of waffling in my answers, because I don't think there is a dogmatic yes or no. It comes down to your situation. So yeah, I countered with saying I'm worried about our data being used for that, but I don't necessarily disagree with the approach.
Yeah, and then the other thing I was going to couple with the likely very low risk of cats shedding virus and infecting other cats is that there hasn't been that large of a surrender rate of animals from COVID households where the owner could no longer care for them. And we are concerned actually that we don't know really whether dogs or cats are coming from COVID households.
Yeah.
We just don't know. So the question becomes, if you have a low risk for cats infecting other cats, I think dogs are probably not an infectious risk, but if you have a lower risk for cats infecting cats, and you don't really know if they're coming from a COVID household or not, unless you ask people, which is a whole nother question right there as to whether you screen every person bringing a cat in if they've been in contact with a COVID infected person. I think we're leaning towards not having any quarantines.
Yeah, I think if you don't know there's exposure, like the conversation I started with the questions from known exposed households, and that's where I was kind of framing my answer. Like a cat with no known exposure just means no known exposure. It doesn't mean no exposure. But again, you're layering risk, low risk on low risk on low risk, right? So if you got a cat where you don't know, like a stray cat could have come right from a positive household, but we can only do so much. So I would rather us focus on the higher risk things. So I don't recommend isolating every cat for COVID exposure, but if you've got one that you know from a positive household, I think it's fair to ask. Because if they've just come from a positive household, at least let you do that risk assessment. So, they just got sick yesterday, then, I think it's reasonable to do something extra versus that cat. But you're right, it's going to be a low number of those that come in my experience dealing with shelters. We still do see them, but I don't think we need to go to extremes and thinking that, every cat, just because we don't know that the household was negative, we're assuming it's positive. Like, I think we can flip it around at that point, as we want a higher level of proof before we do anything substantial.
Thank you.
But we don't know, right? It's all cats. We're all making it up as we go. And I think a lot of it comes back to, if your shelter has no isolation, you're going to be more liberal to what you do. If your shelter has isolation capacity, then you do a little bit more. Part of it's comfort with informed consent too. I think that's one of the things we need to think about. If we're getting rid of them fairly quickly and they're coming from a known household, then what do we tell the prospective owners? And I think a lot of them are going to say, I'll wait a few days, my experience anyway, but it brings up a couple of different issues. Yeah.
And I think Gina had asked, she said, more exposure to humans or to infect other cats. So I was wondering, I think she's asking if the exposed cats are more of a risk to other cats in the shelter or to the humans that adopt them, is the way I'm reading that question.
Well, I guess it'd be both. If you bring in a cat that's infected, depending how you house the cat. So if you're isolating and hoping there's going to be limited risk of cat-to-cat transmission, and we don't really know, if there are cages, facing each other, really close proximity, or if they're, if they happen to be in anything where they can go nose to nose, there'd be some cat-to-cat transmission risk. I suspect that's pretty low risk though in a shelter. I think what we're more worried about is transmission to people, adopters or our staff. And it's lower risk. And like Cindy was saying, we were saying stuff at the start, there's a lot more, when there's a lot less in the community, then you can be a lot stricter, right? It makes sense to be a lot stricter when the community is blowing up, then the relative contribution of the animals is lower and lower. So we kind of have to keep reassessing these things as we go.
Perfect. And I'm just going to go back up to someone has asked, I have had employees test positive for COVID-19 recently with 3 doses of vaccine. I have had many staff members asking about a 3rd dose being implemented in the future and asking what the purpose of vaccine mandates might be if staff can still become infected and transmit it to others despite their vaccine status. What exactly would the goal be of a 3rd dose vaccine mandate in workplaces if this were to be implemented?
It's kind of the same reason we vaccinate animals, right? We give boosters of animals because we know it's not 100%, but it's going to help. So the 3rd dose is going to reduce your risk of getting infected. It's not huge protection on infection, but it will do something on infection. It's going to substantially decrease your risk of severe disease and death. And most people might say, well, I'm a 25-year-old, otherwise healthy person, but there are enough of them that are getting seriously ill. And if you're looking at long COVID rates that are running in the 10 to 20% range, like we just don't know what's going to happen. This causes some pretty strange things. Again, back to my hockey thing, I know a girl in our association on another team has been out fairly non-functional for the last month and a bit after COVID. And this is a 16-year-old, otherwise very healthy, doubly vaccinated. So back in the fall, had been 2nd dose person. And, we don't want to base our life on N=1 single events, but we just have to realize that just because you think you're low risk, it doesn't always pan out that way. And, vaccination is cheap in terms of it's free. And it's easy and it's low risk. You look at Alphonso Davies, Canadian soccer player, right? He's been out with myocarditis. So very health and disease associated myocarditis, like epitome of health. And he's been sidelined for a few months with myocarditis. So young, healthy individuals can be impacted by this. So I think that's a lot of it is you're trying to protect yourself. And yeah, there's less of a population effect than we had hoped, but there is some population effect. So just because it's not perfect doesn't mean we shouldn't use it, because if perfect was the requirement for something we did, we would have no treatments or vaccines in veterinary medicine.
Okay, I think the last question that we have time for is Lisa asked, do you still recommend wearing a mask and a face shield when in contact with wildlife or just some species?
Yeah, wildlife are tough. We've been doing a lot of wildlife stuff lately with rehab groups because we just don't know, and we want to get into more screening. So the problem with wildlife is that we know some species are susceptible and we don't know about the rest. So we know that deer are susceptible, and we know that deer can transmit it deer to deer, and we've had evidence of a deer variant that's emerged, and that's a big concern. We know that mustelids can transmit it really nicely. And we don't want to infect mustelids, and we don't want to get it back from them. So we got a couple of different issues there when it comes to wildlife. And then we got the other species like raccoons and squirrels and the like that we don't know that they're susceptible. We've got data that says they aren't, but for raccoons, it's from 3 raccoons from a study done with way beyond Omicron, before Omicron strains that have nothing to do with what we do right now. So we can't be completely confident. So basically what I say is we have species that we know can transmit the virus, and then we have everyone else. And we want to focus on the ones that we know. So when we're talking with rehabbers, it's like we want to make sure we're taking extra precautions against those high-risk species. And that's, ideally we got vaccination, we got masking, we have everything else. And it depends on what's happening to the animal. So the 3 main risks really we could package them off for wildlife, because one is us getting infected from wildlife. So that's going to be wildlife that might have their own variant. And that's deer right now, as far as we know. So getting it from deer, but it could be other species. Another is going to be, us infecting that wild animal that then takes it into the wild. So we're just creating more potential exposure for strains to move around. And the other is spread within animals. So we spread it to one animal, and then they spread it to other animals that are in the facility or may go out. So if we've got an individual that's going to be kept captive for 2 months, the risk is a lot lower. If it's an individual, because if they get infected from you, they're going to burn it off unless they're mixing with everyone else. It becomes more of an issue if this might be a quick capture and release. or if it's quick capture and going into a different rehab facility with a lot of animals, where if you infect that animal, it might then infect a bunch of other people. Again, for me, masks are just easy when we don't know. So I'm less worried about getting infected from a raccoon or other species we don't know about. I'm more concerned about us infecting them. I'm concerned about us getting infected from mustelids and deer. So the face shield, eye protection thing, I think is reasonable when you're working with deer for sure at this point, because we don't really know what's going on, but we know there could be something there. For other species, I think a mask is still prudent. And eye protection, I'm not sure as eye protection doesn't hurt. I wouldn't say it's a thou shalt thing for me. It's not a bad idea, but I'd be more focused on eye protection for the known transmitter species.
Wonderful. Well, thank you so much, Dr. Weese, for sharing your time and your expertise. And as always, your help guiding us through this ever-changing pandemic is greatly appreciated. Thank you so much for your time. We really, really appreciate it. So we can do
No problem.
virtual applause if we can figure out how to do that. Thank you
Thanks,
so
everyone.
much. Take care.
Yeah, you too.